Welcome, everybody. Welcome. Welcome to the Worcester Senior Center and the Distinguished Speaker Series. Today we welcome Dr. Alissa Lamoureux. She is a board-certified dermatologist and doctor of osteopathic medicine, a fellow of the American Osteopathic College of Dermatology, and a fellow of the American Academy of Dermatology. Dr. Lamoureux will talk about dermatologic care, including medical, surgical, and cosmetic services. Coffee and today is sponsored by Vibra Hospital and Loyal Home Care. Thank you very much for offering that wonderful service to our seniors. Lunch is sponsored by Fallon Health, and the East-West Band will entertain us during lunch. Welcome, Dr. Lamoureux.
I wanted to say thank you for inviting me today to be here to speak to all of you. It is a true honor to be here. I hope that you were able to learn a little something from the lecture today, and I'll be here after if you have any questions. I'm happy to speak with you one-on-one. So, as Suki said, I am a board-certified dermatologist practicing in Shrewsbury, and the name of the practice is Skin Dermatology. And first thing I was just going to talk about a little bit is about our practice, to kind of get to know what it is that we do in dermatology practice, and what the expectations are when you come to a practice like ours. At our office and in a dermatology practice, you're able to see a whole bunch of conditions. You can see medical patients, you can see surgical patients, you can see patients for skin cancer screenings, you can see patients that have concerns of rashes or growths. We see a lot of patients because they have concerns of acne, and also we're able to see patients in all age groups. We can see patients from when they're an infant all the way till their later years in life and take care of them and address their concerns. So that's kind of unique about dermatology, and a majority of what we do is typically in the outpatient setting. We don't have to go into a hospital much. We're able to address many concerns right there in our clean, state-of-the-art facility, and get most things taken care of in that location where it keeps your care under one roof, one umbrella, and you don't have to be moving from practice to practice or location to location, which is really nice. So we try to do a bit of everything in our practice. We try to do the medical aspect of dermatology, the cosmetic aspect of dermatology, and then also the aesthetic aspect of dermatology and your surgical side. So the level of care should be individualized when it comes to your healthcare in general. You have to be a patient advocate these days, advocate for yourself. Sometimes it's difficult to navigate through the healthcare system, but again, the philosophy that we try to embrace is trying to help you navigate through that, because we know that healthcare is challenging. There's many challenges outside of just seeing patients. There's challenges with maybe access, transportation, technology, insurance, and we really try again to look at how that whole experience affects a person and a patient, and how to help them navigate through that as seamlessly as possible. And when it comes to medical dermatology, the things that people are commonly coming in for are skin screenings. They're coming in to make sure that there's no signs of skin cancer, have their brown spots looked at, their red spots looked at, have a head-to-toe skin screening. They also come in for rashes. People will get contact sensitivities or rashes from coming in contact with a tree or a plant. Their patients are coming in for acne. There are other life-threatening rashes that may every now and again show up. And then also for surgical care, if we were to take a biopsy and find something that showed a skin cancer, most of the time it will need additional treatment. So we're able to offer many of those services in the office. And then, like I had mentioned, we also offer some aesthetic services as well. So when it comes to skin cancer screenings, people will ask, how often do I need to be seen? Do I need to be seen in the first place? What am I looking for? So there's definitely different levels of risk just inherently when it comes to patients. Some people have risk because their skin is fair and they have light eyes and light hair, and that would make them be more prone to burning. And if you burn more, you're at a higher risk potentially of developing skin cancer in a lifetime. So that could be maybe a higher risk person. A low risk person is maybe somebody that has more of olive complexion where they haven't really had too many sunburns and they've been really good over the years at avoiding the sun or using really good sun protection, and they don't have a family history really of any skin cancers. There may be other reasons why you're at risk because of family history, somebody in your family having a risk of melanoma, like a first-degree relative. Like if you're a parent, your children could be at risk if you had the history of the melanoma. Or you know, sisters and brothers could be at risk. If you are somebody that takes a high-risk medication that makes you more susceptible to burning, that can put you at risk for skin cancer. Or if you're a person that's had organ transplantation in the past, sometimes transplant medications will put you at higher risks for skin cancer. So in those particular subsets of patients, practitioners maybe that are treating you for your post-cancer surveillance for, you know, maybe something that happened in the past might say, hey, you know, you're on this medicine, that can put you at higher risk for skin cancer. Now I need you to go see the skin doctor once a year. So different factors will make you be susceptible again to sun damage and things happening on your skin. And then in a lifetime, I always tell patients sun damage is cumulative. I say it's not what you did yesterday that's going to show up tomorrow. It's all the years, because people will come in time and time again and tell me, oh, I don't get in the sun. You know, I hate the sun, but they got a lot of spots on them. And they say, but you know, 20, 30 years ago, I used to do that baby oil and iodine and the reflector, and we say, oh yeah, we've heard this one before. And so, you know, and I tell them, it's you know, at that time your skin maybe tolerated it, you recovered from a burn, or you turned dark and then your skin faded when you got out of the sun. But you know, that repetitive nature of doing that over the years ended up adding up in spots on the skin. And as time goes on, spots will sometimes evolve and change, and sometimes spots that weren't there a year before show up, and that maybe isn't a good spot. So surveillance definitely gets more important, I would say, as we age, because the exposure to the sun has been compounded over the years. You know, people that live closer to the equator, people that spend their winters in Florida, you know, people are active. They're getting outside, walking and playing pickleball and doing all sorts of things. And, you know, that's getting outside. I always say it's important to live your life and be active, but, you know, you do the best you can. And if you can, you know, put some sunscreen on and wear a hat and sun protective clothing, you know, that's going to help. But we can't maybe change what happened 20, 30 years ago, but we definitely can keep an eye on you and see you year to year, because in a year you definitely age, things can change. So, you know, the incidence of skin cancer goes up, unfortunately, as we age. I always tell patients, or men in particular, the highest risk of skin cancer is men aged 50 and older. So we talk about surveillance in that age group and how it's important. Even if you don't have a history, no family history, no personal history, just to start getting in the habit of doing skin screenings. They're usually quick, painless, and we try to educate as much as we can, and sometimes, you know, we find things that we didn't anticipate finding. So I think for the time that it takes to come out and do a skin screening, they're definitely worthy procedures, and we're available for that, and we can help develop a plan once we see you once for what needs to be done in the future. So there's a whole gamut of things that we see when it comes to, say, skin cancer or precancerous lesions. So precancerous lesions are spots on the skin that maybe will never turn into skin cancer, but they're a marker definitely of sun damage. But because they have that chance of having that progression to skin cancer, pre-cancer, potentially becoming cancer, I always tell patients, you know what, it's probably better for us to treat it now than wait a few years and wait for something to happen or change. So we try to be preventative in that way, to essentially take care of things when we see it and not put it off for the future. And there's different ways that we go about treating precancerous lesions. We first might take a biopsy of it because we're not sure if it's precancer or skin cancer, and then when we get it back from the lab, it tells us it's something precancerous, and it still might need a little treatment, but it puts us maybe on the radar to think, okay, you've had some precancerous lesions. This is definitely a warning sign for the future, and definitely another reason why we should be seeing you more regularly. And most of these things are quick. You know, nothing's completely painless, but we try to make it as painless as possible, get you through the process. And sometimes, you know, things will start with having a biopsy. Other times we're able to say, okay, this really just looks like we can treat it right now here in the office. We'll often do something called liquid nitrogen, which is a very cold spray that's destructive in nature, and usually that will take care of some precancerous lesions. Sometimes when a mole is what we would call precancerous, meaning it's not skin cancer yet, but it's having some features that are looking a little bit alarming, and in the future maybe it could evolve. Sometimes we'll actually go back in after we've taken a biopsy of what would be considered a precancerous lesion and take a little bit more. We'll send more back to the lab and make sure we really get rid of it in its entirety so that we don't have to worry about it for the future. And that can be through, sometimes it's a little surgical procedure in the office, other times it's through just another type of biopsy. But essentially, precancerous lesions are things that we definitely want to pay attention to. Sometimes we don't know for sure. When we're looking at it, if it is precancerous, we might have an inkling that that might be that, and we might take a biopsy to confirm that. But essentially, the precancerous lesion is kind of the first step in things that might draw some concern and, again, solidify the need for ongoing surveillance and skin cancer screenings. And then when it comes to, say, skin cancer, you know, the word cancer obviously can be frightening. So when we call patients and tell them, oh, you have a basal cell skin cancer, you know, that can be concerning, and I completely understand that. And so our team is trained very well to be able to, you know, walk patients through the process and answer questions. But most skin cancers, when they're caught early, are very treatable. So again, another reason for ongoing surveillance and seeing patients with some sort of frequency for skin screenings. The most common skin cancers are typically caused by sun damage. Those are the basal cell skin cancers, and then also the squamous cell skin cancers. Basal being the most common, typically not traveling through the body unless there's been maybe an extreme neglect and the spots become very large. But typically, the risk is just there on the skin. And I always tell patients, you know, it's not likely going to go anywhere, but we don't want to leave it there because it certainly can become locally destructive. So in that circumstance, we usually do some sort of a treatment in the office. Sometimes it's as simple as a cream, a medicated cream that you would do at home. Sometimes it might be a procedure that's relatively quick where we destroy the cells through a scraping and burning technique. Sometimes we'll choose excision, which is cutting and sewing, cutting out the skin, sending it back to the lab for analysis, and putting some stitches in where we've removed that cancerous skin and making sure that, you know, it heals nicely that way. And then in some circumstances, based on the size and the type of the tumor, sometimes we do have to get some other specialists involved based on potentially location, again, the size of the lesion, the subtype of the lesion. We sometimes have to bring on other surgeons or other dermatologists that are specialists in a procedure called the Mohs technique, which I will go over a little bit more further on in the presentation. So people will ask, you know, like, well, what does a skin cancer look like? How am I supposed to know with all these spots that I have on me, like, which one is a skin cancer? So I always say, you know, something that is sitting on the skin that seemingly is not healing is always a warning sign. If you keep picking at the same spot every single day and you're scratching it every day, well, surely that's not going to heal. But if you don't touch the spot and every day it's bleeding, well, that's a warning sign. And you know, after a couple of weeks, you know, at the greatest, a month, a spot should heal if you're not traumatizing it. And I usually say if it's not healing for that length of time, then that's a warning sign. Basal cell skin cancers can definitely have some different looks. Sometimes they just look like a red patch on the skin that's a little bit scaly. Sometimes they will actually look like a bump, like a little pearly looking bump, kind of shiny in color. Other times they could have kind of like a, it almost looks like a peak in a valley. There's a little bit of a dip in the center because there's a little erosion in the middle. But they can be very subtle and, again, sometimes hard to pick up on. Very common, however, to get them in places where you've gotten more sun. So the highest risk location tends to be the head and the neck. So if you have a non-healing lesion on the head and the neck or anywhere on the body, that would be, you know, a lesion that would be concerning and something that we'd want to take a look at. And the most common subset of that type of skin cancer is the basal cell skin cancer. And again, very treatable and curable. The second most common type of skin cancer is the squamous cell skin cancer. Now, there's a little bit higher risk of a squamous cell skin cancer turning into something that could travel through the body and go elsewhere. It's still pretty small risk, but the risk is higher because there can be some more aggressive subtypes of this type of skin cancer. And you can see that these photos show some eroded spots, things that look a little crusty, kind of like that spot on the lip that looks like it's probably been bleeding, but it looks like a really good bump there. And these are all kind of showing spots, again, in places where the skin's seen more sun. Sometimes squamous cell skin cancers I always say they erupt like a volcano sometimes. It looks like it's a bump on your skin that came out of nowhere, and it's got a little dell in the middle, like a little central indentation. That can be the sign of a squamous cell skin cancer. But there can also be very early types of it that just looks like a little dry patch on the skin. Some people will say, oh, well, I have eczema or I have psoriasis, and that's how my eczema looks. But I've been treating it with my steroid cream that usually gets rid of my eczema, and this spot just won't go away. Well, then that becomes something that we might be a little bit more concerned about, and in that situation, that could be a skin cancer. So again, early detection is always key when it comes to skin cancers, and the most common subtypes of the skin cancer are the basal cell and the squamous cell. And then there's that scary skin cancer that we all, I think, probably have heard a bit about, which is melanoma. Those types of skin cancers are the ones that typically will come from a brown spot most of the time. There are some times when they actually come from a lesion that's more of a white spot or a pink spot that doesn't really have that look of looking like a mole or a freckle. So those can be a little curious and harder to detect. But typically when it comes to melanoma, it's a mole, it's a freckle. It looks like it's probably a spot that has multicolors and has some irregularity to it. And they use this nice mnemonic to help you kind of try to identify warning signs of melanoma at home, either on yourself or on a friend. And they call them the A, B, C, D, E's of melanoma. And I always tell patients, these are guidelines. It doesn't mean every spot that has these features on your skin is melanoma. But if there is a spot that has some of these features that maybe hasn't been there for a little while or looks a little different than the rest, then that certainly is a warning sign and something that you should be calling your dermatologist to make an appointment to have them take a peek. So A stands for asymmetry. Asymmetry means, I always say, if you draw a line down the middle of it, if it looks like a square on one side and a circle on the other side, that's asymmetric. They're not the same mirror images left to right. So that's one warning sign. B is border. The border is not regular or circular or oval shaped. It's more jagged and irregular. That can be a warning sign of a mole that's changed or could be melanoma. C is color. Color could be multiple colors. It could be maybe it was brown and now it's turning pink or has a little blue hue to it or looks a little gray. So the color could be changing slowly in time, and that could be a warning sign of something being a melanoma. And then we talk about the size. So rule of thumb, bigger lesions could be more concerning. So what we usually give a reference to is a pencil eraser. That's about 6 millimeters in size. So something bigger than that could be a warning sign of a skin cancer. So that's another feature to look for. And then the last one is a newer criteria that was added. That's the E, and that's evolution. So I always say it's changing. If it's itching, bleeding, burning, not healing, it was flat, now it's raised. It was, small, now it's big. That's evolution. The lesion is changing. That's a reason to reach out. And again, there are certainly plenty of lesions on patients that could follow some of these criteria that are not bad, but when you come in and you see us and we do a thorough skin check, we're able to, I always say, see the forest or the trees, help make sense of what is good and what's bad. And sometimes we look at something and we think, well, maybe that's not following the criteria, or it's not looking like the way the rest of the moles on the body are looking, and we should take a sample. We may not be 100% sure that it's melanoma at that time, but again, we talked about precancerous lesions. They can be moving along a spectrum. They can start as precancerous and be a little bit funny and not be melanoma yet. So that's where we would take a sample, sent to the lab, and have another provider who's a pathologist who's trained to look at skin under the microscope give us a diagnosis, and then we in turn give you a call back once we have the results back and tell you what was found. And if it is something like melanoma, then it would need further treatment, and we advise you on what the next steps may be in that regard. And then once you have something like a basal cell or a squamous cell or a melanoma, then your surveillance is actually going to increase. you're no longer just going to come in once a year. We're going to be seeing you more frequently. The skin exams, I always say, are going to tighten up. So at the least, we usually would see you in 6-month intervals if you had like a basal cell or a squamous cell. And then when it comes to melanoma, we're usually starting with actually like 3-month intervals. We're seeing you that frequently to do skin checks and check your other, the rest of your skin and also your lymph nodes, feeling for other places where potentially there could be signs of melanoma because there's a higher risk in this subset of cancer of it traveling through the body and causing problems elsewhere. In other locations, I always say, melanoma can happen in places where you had a lot of sun, but it also can happen in places where the sun doesn't shine. It's important to look at the bottom of the feet. It's important to look between the toes. With somebody, with a higher risk type or, with a lighter skin color or having a history of melanoma, there's such a thing as ocular melanoma where it could actually happen in your eye where you can't even see it. So again, surveillance is important in bringing on other providers to help us participate in your care is part of taking care of you once you have a skin cancer. So in terms of treatment, we kind of mentioned a little bit about what treatments may be offered if you did have a skin cancer, but when it comes to, say, the basal cells and the squamous cell skin cancers, there can be chemotherapy creams that can be used, that can be applied at home. We talked about some of those procedures like scraping and burning or excision, which means surgical removal, or that Mohs technique where you take a skin cancer off layer by layer and have it looked immediately under the microscope to make sure that you have cleared the location of the tumor so that you can rest assured that the skin cancer is gone. Sometimes patients need referrals to other providers. Sometimes people will need more advanced adjuvant therapy, we would call it, like chemotherapy and radiation, even for skin cancers. So there are essentially multiple modalities to take care of skin cancer, but most of the time, we're making sure that we have that surveillance first, and then we're figuring out what's going on, so we get you on to the next step, which is the treatment, and walking you along the process. So in the office, we do provide some surgical dermatology. We provide excisions of things such as melanoma on the body, or squamous cell or basal cell. Typically things that are more isolated to the face depending on the location and how the size of the lesion. We may refer some of those cases out to either a plastic surgeon or a Mohs surgeon where that technique is utilized, where the least amount of tissue is taken. There are laser surgeries. There are other things that potentially can be done. And then, we're guiding you along this process too, because sometimes there's more than one way to go about treating something. And the comfort level of one person, what they want to do versus the comfort level of somebody else could be different. So we try to offer and advise people on what the techniques and modalities may be there. We obviously give our advice on what we think the best one will be, but we're definitely willing to have a discussion when somebody may have a question or want to potentially try something a different way. We, of course, want to make sure that your cancer is gone, but we do, because there are multiple ways to take care of things, we do offer options and try to come up with the best treatment plan for you, because at different stages of life, the treatment plan definitely could change. So we talked a little bit about the skin cancer removal. Typically it's done in the office or sometimes in a surgical suite depending on the person that's doing the procedure. And most of the time that day, the tumor is removed in its entirety and your skin is maybe the piece of it sent off to the lab for analysis. Sometimes with that Mohs procedure, it's analyzed immediately and made sure that you have have the security that your skin cancer is gone. After a surgery, you have post-care you have to do. So typically you have stitches in, maybe for a week, maybe 2. You're given instructions on how to take care of your wound. We're there definitely to walk you through the process and help make it as simple as possible, and definitely have a little homework involved. But most of the time, the aftercare goes smoothly. And I always tell patients, The limitations, we try to kind of limit movement in the area. We say you can go about your normal activity, but the favorite question is, can I play golf tomorrow? And I'm always like, well, if you swing the club and wherever you're swinging, you feel pull on that area where I put my stitches, let's not do it. Let's take the break while the stitches are in. But if the spot was on an area that's not putting too much pull, we'll allow for some gradual activity during the time of the stitches being in. But you definitely can go about normal activity. We usually have patients plan surgical procedures. I usually say don't plan it around the time when you're going to be on an airplane. You got to lift luggage up and down in a overhead bin, or you're going on vacation next week and you want to go swimming. Let's wait till you get back. So we try to accommodate things and understand what other lifestyle or what things you may have coming up that might kind of get in the way of what your plans are, and try to plan accordingly. We touched a little bit briefly upon that Mohs surgery. So again, that's the procedure by which you take skin cancer off in a layer-by-layer technique. And that's tissue is immediately looked at under the microscope by the dermatologist that's actually doing the skin cancer removal. So part of being a dermatologist is that we're also trained in looking at skin under the microscope. So we can serve as the surgeon, but we can also serve as a pathologist. And there are some dermatologists that have gone on and had additional training and are trained in this technique. And if we are requesting this technique, we do typically partner with some of the local experts and have you see them for this procedure, and then follow up with us after to have your ongoing care in your surveillance for your skin moving forward. So we may have to have you have a spot on the face taken off with the Mohs surgeon, but then you usually come back to us after so that we can continue with your skin cancer surveillance. And the rate of cure with the Mohs surgery is very high because that tissue is looked at immediately before the skin is sewed back up. So typically on places where there's a high risk of cosmetic disfiguring, like the face, we opt for the Mohs surgery because I always say it's going to give you the smallest surgical site. They're only going to take the tissue they need, and it's going to give you the highest chance for cure. So now, we talked today about, what does the audience want to hear? What do they want to learn about? And, we talked about how we do a lot of medical dermatology. We look at a lot of patients for their skin screenings and rashes and acne and children and babies and eczema. But then we do surgical dermatology, but then we have that other aspect of our practice where we focus a lot on cosmetic services, because people are definitely concerned about the way they look, and it's not something that stops at a certain age. We have people well into their 80s that come in and have cosmetic treatments, and that makes them feel good, and I say that's wonderful. Do what you see and what you want to do to make you feel good, because aging is a continuum. It doesn't stop at any point in time, and we can always help you along that continuum to help enhance your look, maintain your look. Maybe you're not looking to change things, but you don't want to look worse in 5 years. So we talk about ways to achieve your goals, and we're able to do that by offering cosmetic services in our practice. So as the aging process goes on, as you can kind of look at in this photo, you have this nice, young, youthful skin. You can see like her jawline is nice and tight. Her skin looks really soft. It doesn't look like there's any crinkles or wrinkles. Her eyebrow is nice and arched and up high. But as she starts to age, she starts to get a little wrinkling around her eye, and her skin right here is starting to look a little crepey and crinkly, and she's getting a little bit of a fold here by her mouth. And maybe she's getting some lines up here on her forehead, and maybe her brow's starting to fall a little. And then she goes on to age some more. She's had a lot of sun exposure over her lifetime. The skin starts to wrinkle more. She's getting a more aged look around her eyes. She's getting more folding. Maybe this jawline is looking less sharp as time goes on. So as we all age, there's going to be this normal progression that is appropriate. Some people age better than others, and their skin maybe has had more protection than others, and maybe genetics played into it, that they just got some good genes and they are aging very gracefully, and other people age prematurely. They age prematurely when they're in their 40s or 50s, or some people it's not till they're later on in life. But essentially, as time goes on, things do change. Things change on the surface, and things are changing below the surface that are causing these shifts to happen. As we all age, our skull actually gets smaller. So that means that the cheekbone that was up here starts to sag and fall because it's not as big. And when your bone starts to get a little less, the skin that it's holding up starts to fall. And that's when women and men start getting the jowl down here, that excess tissue that they don't like, and they start getting more folds in places where they didn't have them before. Around the mouth, people start getting crinkles and wrinkles. I mean, that can just be due to talking and expressing yourself over the years, and so can wrinkles be due to that. But we know as we age too, our jawline starts to change. It starts to get a little smaller. So the skin that's sitting over it is actually starting to look baggy or looks like it's more wrinkled because it's not as stretched anymore. It's not as full. So these are some signs of some aging, and then some concerns of aging. I mean, it could be wrinkles, it could be cellulite or dimpling of the skin. There could be pigmentation that's happening on the skin from lots of sun exposure, hanging out in Florida, going to the Cape in the summer, being out on a boat, being an active person on the golf course. You start getting discoloration on your skin or on your face. There might be medical reasons that cause you to have discoloration, like rosacea. People get really rosy cheeks. They don't like it. So there are ways to treat things medically, and we always try with the medical approach first. And if we don't get to the person's goal or endpoint, we talk about complementary services that can complement what you're doing medically to help in achieving your aesthetic goals as well. Because sometimes we give patients medications for rosacea where it's that redness that happens across the cheeks, but the medicine doesn't really make it all go away, and they're still red and they still don't like that. So then we talk about other modalities such as lasers and other ways that we can help make the person feel better about their condition and make that condition be less apparent. And then coming to, say, skincare. We have skincare routines that we can provide patients, advice on, and we always talk about a good routine, starting with cleansers. Cleansing the face twice a day is important. Always ending with a moisturizer with sunscreen. Some people, all they want to know is get some advice on some good skincare. And we often have samples of things that we give people during their consultations. We often have product recommendations that we can give, but we talk about ways to make a good skincare routine and sticking to it, because again, I said that 365-day of the year routine is very important to be part of an overall good skin health. It can be a complicated routine or it can be a simplistic routine. And I always say start with simple and then add things in after. Because if you can't do the simple, it's going to be much more challenging to do the complex. But a good skincare routine can start at any time, and it definitely can help enhance the way that your skin looks and the way that it ages. So there's definitely always the time for us to talk about good skincare routines. We talk a lot about skincare routines even just during our medical visits. We're always giving advice, trying to tell people, guide them along the way, asking them what number sunscreen do you use, and how are you taking care of your skin. So when it comes to sunscreen, it's the cornerstone of anything that you're going to do for your skin. We usually talk about sunscreens that are a minimum SPF of 30 as being a good start. I always say 30 to 50, not much above 50 gets you that much closer to 100. It's important to put your sunscreen on like 15, 20 minutes before you go outside, and then reapply every couple of hours, especially if you're sweating, swimming, you've been in direct sunlight. It's great to seek shade if you can, sit under an umbrella, wear a hat. Sun protective clothing I'm a huge fan of. It's easy, I think, to just put a long sleeve shirt on or a rash guard and not have to think about it as much. When it comes to the sunscreen, they don't filter out all the rays. They don't filter out your ability to tan. People worry, oh, I'm not going to get a tan. And I'm like, well, I didn't really want to hear that. But I tell them, you will get a tan through that sunscreen. If you're prone to tanning, you'll get a tan anyways. But we're trying to prevent the burning. We're trying to prevent the changes on your skin that's going to produce damage, potentially cancer, precancerous lesions, and also potentially premature aging, because that's what the sun does. It breaks our collagen, and when your collagen is broken, you also get more wrinkles. So it's part of a good skincare routine. They say the size of a shot glass is the amount you want to put on your entire body. So you got to put a significant amount on if you've got a full body to cover. Some people just put a little, slap it on, and they think they're done, and they wonder why they got a burn. Well, they probably just didn't put enough on. And then there's those key areas everyone forgets about, especially the guys on the golf course. They forget the top of their ears. They forget behind their neck. those areas are very prone to burning, high risk of skin cancer as well. So we talk about wider brim hats, maybe not the baseball hat anymore, because if you're not going to put my sunscreen on, you're going to keep getting burnt there. So we talk about maybe changing behaviors a little bit, or really getting in the habit. Try to give them some little samples. Put these in your golf bag when you turn, you're at hole number 9, reapply, so that we can try to create good behavior. So we talked some of these things. We talked about, sun protective clothing, and children are important to start creating good behavior when they're young. I think kids nowadays, they're lucky because parents are pretty diligent about sunscreen. They're diligent about rash guards and hats. If I go to the beach, I'm always impressed. I'm like, wow, look at all these kids that have hats on and sun protective clothing, and the kids are sitting there getting the sunscreen applied. They're used to it, which is nice, because they're going to have an opportunity as they get older to protect their skin and maybe prevent some of these bad things that can happen, and not have to worry about the things that maybe people that didn't have the access to sunscreen at an earlier age or didn't know about it could potentially be at risk for. And I always tell patients, that people are like, well, I don't use the sunscreen in the winter. Like, I don't put it on in the winter, but, I still get out on the golf course in the fall, and I go skiing, or I take walks every day with the dog. And I say, well, you know what? You're still going to get the sun through the trees, in the clouds, in the winter. It reflects off of the ground. It's just an important behavior to get in the habit of doing. Get it in your moisturizer. Put it on a daily basis. If you're going to wear a V-neck shirt that day and you're going to be out sitting outside with a friend having lunch, make sure you drag that sunscreen right onto that area, because you don't want to be caught without it, is what I usually say. And if you use it regularly, then you make it a habit. When it comes to the skin, and we talk, some other things we think about is like, how does your diet affect your skin? How do we enhance what I put into my body to help my skin be healthy? Diets that are balanced are helpful for everything, all the organs on the inside, but also the skin. Staying hydrated, drinking plenty of water, eating foods that are high in vitamins, eating healthy fats, staying away from things that have too many hydrogenated oils, things that potentially will cause more damage in the long run. Internally, can wreak havoc on the skin externally as well. And we find in some conditions like that there are foods related to them. And patients will be like, well, should I eliminate this from my diet? Should I take this out to make my acne better or to get my rash to go away? And what I usually say to patients is, if you think there's a link, like every time you have too much ice cream, your skin breaks out, well, maybe you have a little sensitivity to lactose, and maybe you should limit the amount of dairy that you're having. Or every time you have too much gluten, your psoriasis gets worse. Well, maybe there is a little link between your psoriasis and too much gluten, and we should try to limit that. But I usually don't tell patients to just take a bunch of food groups out of their diet to help to see if their skin's going to get better. I try to have them kind of do a little research, a little soul searching, figure out what they're doing in their diet that might be to an excess, and if it seems like there's a link with their skin getting aggravated, then that makes sense to try to do an elimination. But all in all, just as you would do a healthy diet to maintain your weight and maintain your health, that's also going to maintain good, healthy skin. And we talked about moisture and hydrating from the inside. I always talk about hydrating from the outside as well. So when you take a shower, people ask, what's the recommendation here? I usually say, when you're in the shower, temperature shouldn't be too hot, and you shouldn't be in there for too long. I usually say, 10 minutes or less. You should be using a hydrating soap in the shower. If you tend to be a little sensitive, pick things that are fragrance-free. Hypoallergenic, fragrance-free, approved by the Eczema Foundation. If you see that on the labels, it tends to be a pretty good product. When you get out of the shower, pat yourself dry. And within the first couple of minutes, that's the most important time to moisturize. And you should be moisturizing head to toe. Maybe you have a different moisturizer for your face because your face skin is more specialized than the rest of your body, and you have something else for the maybe neck down. But essentially, getting in that habit every single day of restoring the hydration after you've kind of dehydrated a little bit in the shower is important. It helps keep the moisture within. And we talk about the consistency of products. Lotions are thinner than creams. Creams have less water content, so they'll be a little bit thicker. So maybe in the summer you prefer lotion because you run a little bit warmer and you don't want something feeling as thick, and maybe in the the summer you're using your lotion, and in the winter you're using your cream, because cream has less water content. Maybe you're just dry all the time and you should pick cream, because again, it has less water content. But getting in that habit, head to toe, every single day, is certainly something that can help maintain the moisture from the outside as well. So, we ran through a nice long presentation. Thank you all for listening and being so attentive. I hope I was able to educate you and teach you a little bit about dermatology and some things that we see, and then also go over some maybe cosmetic and aesthetic things that you weren't so familiar with, and tell you a little bit about our practice. And I'll be here after the presentation to answer any questions, and it was a pleasure speaking with you all today. Thank you.